Hello, my name is Ino, so welcome back to my channel. This is Work and Wonder. Please, if this is your first time seeing my video, this is Work and Wonder. I talk about nursing stuff, I talk about traveling, I talk about job opportunities. Kindly subscribe to my channel, and anytime I post a video, you'll be notified, and then you come straight here and come and take a look at whatever video that I have posted. So some weeks back, I started a series on mental health Osce, and I must say that a lot of people have been contacting me. I'm very grateful for you subscribing and watching my video. So I've had a lot of mental health nurses contacting me, especially those that just got into the country and then they are preparing for their mental health Osce. As I said, I myself, when I started preparing for my mental health Osce, I tried looking for videos on YouTube and there was none. Assessment, the skill station, with the exception of those that you can also find in the adult nursing. Those ones, there are videos on them, but those ones that are very specific to mental health nursing, I must tell you that there is no video. In fact, my reminiscence therapy video is the first on YouTube, and I'm very happy that a lot of people are watching and then they are commenting and then they are asking for more. So today I'll also be talking about one of the stations. Most of you have been saying that I should do a video on the assessment station, but then the assessment, if I don't get another person, we cannot practically do it. So what I'm going to be doing today is that I'm going to give you an overview of how the assessment stage looks like, or what is expected of you in the assessment station and the mental health Osce. So without wasting much time, let's go straight into it. I'm going to try as much as possible to break it down so that you'll be able to understand every bit of it. It's quite a lot because the mental health Osce, the assessment is quite broad, but I'm going to try as much as possible to break it down for you to be able to comprehend. So as I said, without much time, let's go straight into it. Yes, so as you know, the assessment stage is the very first stage in the API, which is the assessment, planning, implementation, and evaluation. Is the very first stage. And the assessment stage, as the name suggests, you are going to assess. So basically what you'll be doing is that you'll be presented with a patient and you sit with the patient and then you talk to the patient. Once you are talking to the patient, there are some things that you are looking out for. You are looking out for problems, you are looking out for capacity, you are looking out for risks, right? These are the key things that we are looking for, and based on these things, if you are able to find them, then that will determine your next course of what action. But then let's talk about it in broad. First of all, the assessment stage comes in two phases. We have the depression phase and then we have the mania or the manic phase. Mania or manic phase. So depression and then mania. And as you know, when these two combined, is bipolar. But then in the exam situation, you are either given a patient that is exhibiting depression symptoms or signs, or you are given a patient that is exhibiting the mania or manic signs. Mind you, the diagnosis can be bipolar, but then when they present the papers to you, there's one of them that talks about the recent past or the past history, and that will determine whether it is the patient is experiencing depression or the patient is experiencing mania. So mania and then depression, these are the two main phases that you'll be presented with, and each of these cases there are some very specific things that is expected of you, and in these two phases too, the tools that you're going to use or even the questions that you'll be asking will vary a little. All right, to vary a little. So first of all, the assessment stage is 20 minutes, so a cool 20 minutes, and trust me, the 20 minutes is more than enough for you to ask all the questions that you need to ask. And then, as I said, it's 20 minutes. So when you get there, you are given a patient. First of all, what you should know is that there are always scenarios, and one of the papers will come with the scenario. One of the papers will come with a scenario, and with that one, you see assessment will be written on it. And then when you read the scenario, there are two cases or there are two things that will be pointed out in the scenario, which you need to be very careful of. First of all, You must know whether you are going into the community or the patient is coming into the community clinic. So there are two things here. It's either you are going into the community to the patient house or the patient is coming to the community clinic. When you read the scenario, it's going to be very specific about it. And in either cases, it's a GP that has referred the patient. So if you are going to the patient house, then the way you are going to ask your questions from the very beginning is going to be different from if the patient is visiting you, or the patient is coming to the clinic. For instance, if you are going into the patient house, you are going to be like, do you know the reason why I am here? That is one of the questions. All right. But then if the patient is coming to the clinic, it's going to be like, do you know why you are here? So you get the differences. So based on the scenario, this will inform the way you are going to ask your question. So please read your scenario very well. If you are going to read, it will take you 2 minutes or 3 minutes to understand the scenario. Make sure you read it and then you understand whether you are going into the community or the patient is coming to you in the community clinic. I hope this is clear. So the scenario determines whether you are going into the community or the patient is coming to you. Then when you turn the scenario paper that they have given you, it has what we call overview of the recent history. Here you have the patient name, you have the patient date of birth, you have the patient GP, you have the patient address. So when you are confirming the patient's name, you ask the patient all this, or you read back all this information to the patient, and now you actually confirm that yes, indeed, assessor, I am with the right patient. Don't worry so much. I'll have a friend come in and then we'll do the practical. This is just an overview. So the very first one is the biodata of the patient. Then the second part will be the presenting history. The presenting history, once you start to hear withdrawal, cry a lot, suicidal thoughts, low mood, then you should know that you are heading into what? The depression phase. But then when you hear something like grandiosity, hyperactivity, not sleeping, engaging in so many works, walking up and down, then you should know that you are also heading to what? The manic or the mania phase. So basically, the presenting signs and symptoms should even inform you of whether you are on the depression phase or you are on what? The mania phase. Then the next one is going to be history of presenting complaints. So basically, the history of presenting complaints is going to tell you what actually happened, and then probably they were the person was sent to the GP, and it also gives you even more information as to exactly what happened. So basically, the patient has tried to kill himself in the last 4 days. The patient has tried to take overdose of some medications. The patient has been locking himself inside the room and is not coming out, and the parents or the people around him or her is concerned. So the recent history of presenting complaints will give you details. So if you ask the patient, do you know why you are here, and the patient says no, this is basically what you're going to read back to the patient and now ask the patient, why do you think this is happening? And the patient is going to give you detailed. Mind you, in the exam situation, the people that are acting as a patient have been given a storyline to tell you. So when you tell them, what do you think led to this, they are going to give you a vivid description of what happened. And it is based on this presenting complaints. When you read it back to them, that is what will trigger their mind to tell you exactly what happened. And then you're also going to have past medical history on this same overview. You are going to have social history. You are going to have drug history. You are going to have allergies. So the overview of recent history, if you look at it very well, it should even give you problems. The problems that you need to get from the patient. At least it should give you an idea of the type of problems that you will get from the patient, and that will help you in your next stage, which is the planning. So make sure you take note of the history. Some people don't read the history. Once they just read the scenario, they ask the patient what happened, and the patient will say a lot. But once you know overview of this history, it will guide you to be able to know that there's very relevant or specific questions to ask the patient. And that will lead me to my next paper that will be given to you. That one is called the candidate note. The candidate note also have some specific headings like capacity, relationship, major life event, living situations, patient self-care, non-adherence to medication, current risks. So basically these are topics which you have to ask your questions. So something like relationship, all you need to do is, how has this situation affected your relationship with your partner? If the person is married, per the history that was given you, or how has this affected your relationship with your family, with your parents? Basically relationship. Ask any question with regards to relationship. When it comes to major life event, what has happened over the past few days? What have you been through? What happened? The patient will tell you all this. When it comes to self-care, you can talk about, has this situation affected you in any way in caring for yourself or in taking care of your hygiene? So these are headings, so it will help you or guide you to be able to ask very specific questions. And mind you, capacity and consent and risk factors are very, very, very important. And one good thing about this sheet is that they are not going to mark anything on this. But then if you are able to make small notes on it, this is going to guide you to be able to ask specific questions. So probably under non-adherence to medication, I'll write, what medications are you on? Have you been taking the medications as prescribed? And when you ask, this is under non-adherence. So when you ask this, a patient to tell you, well, I've been taking it, sometimes I don't take it, then you now follow up. What makes you not to take it? Probably the patient is having side effects that he or she is not so comfortable with, or the patient doesn't even have much knowledge about the drug. Once the patients I don't have much knowledge, I get a lot of adverse effects from this medication, then you should start to talk about non-compliance as a problem. So based on your questions, you should be able to get as many problems as possible. So that is the third sheet, which is a candidate note. This sheet should be able to guide you to ask specific questions. And then, as I said, in the assessment, basically we have the depression phase and then the manic or the mania phase. If it is depression, it's also going to come with another extra tool, which is called the PHQ-9. This particular PHQ-9 is a tool that is used to assess depression, right? And then it has some very specific signs and symptoms, or some very specific questions that will tell you more about the patient's situation. Questions like if the patient is feeling depressed, if the patient is having thought of harming himself, if the patient has been eating, if the patient has been sleeping well, all these, and it is graded on 0 to 3, where 0 is the least or 0 is nothing at all, and then 3 is the highest. So for something like poor appetite, the patient says 3, then you have to probe further. Since when have you taken food? Well, I've not eaten for the past 5 days because I think I'm Jesus and I'm making, I should be able to fast for 30 days. Once you start to hear things like this from the patient, then you should know that nutrition is going to be a problem. Or the patient says that I've been having this huge thought in my mind to build the biggest tower in the whole world. So I've been drawing and I've not been sleeping. I've been drawing this and I've not been sleeping for the past 3 or 4 days. And you should also know that sleep is a problem here. So the patient will tell you he's scoring at 3 because he has not had any sleep at all. And this is a clear problem. So when you get to the planning phase, it becomes very easy for you. You get it? So the PHQ-9 should be able to help you to find problems and then risk factors. I will do a video dedicated to only PHQ-9 in one of these series that I have started. But then, as I said, it is in the depression phase that you are going to have the PHQ-9. In the mania phase, you are not likely to have a PHQ-9. But then I'm not saying you are not going to have. You are not likely to have a PHQ-9. In most situations in mania, you are not given a PHQ-9. But in some situations, you might be given a PHQ-9. So note, but mostly for all depression cases, you are going to have the PHQ-9 tool, which you will use to do your assessment. So basically, these are the sheets that will be presented to you, whether it is mania or it is what? depression. Here, there are just some key things that you should take note of. You have to bear in mind that in assessment, first of all, you should know where you are going to do the assessment, whether it's going to be in the community or the patient is coming into the clinic. Then the second thing is that the sheets that you have been given, make sure you understand them, make sure you read and understand them. And then based on them, you'll be able to ask the relevant questions. And here, all you should note is that one, you are looking for the capacity, whether the patient has capacity or not. When we say capacity, whether the patient has a capacity to keep himself safe in the community and continue treatment in the community, or the patient does not have capacity, especially in cases of depression, something like suicidal thoughts, when the patient tells you that life is worthless and I feel like taking my life. Once you start hearing things like this, you know that it is dangerous, and you even have to probe further and ask whether the patient has a plan. Some of the patients will tell you, I have a plan to kill myself, and they will even tell you how they are going to do. In this case, the patient does not have capacity to keep himself safe in the community for treatment. So you would have to call in, or you have to recommend admission. So whether the patient has capacity or not, if the patient has capacity, fine. The patient can continue being nursed in the community. But if the patient does not have capacity, then you should note that here admission you should recommend admission. You don't tell the patient, I'm going to admit you, but you are going to tell the patient that you are recommending admission, and then you give reasons for that admission. And now you ask whether the patient is consenting to that or not. If the patient says, I consent, basically the patient is coming in as an informal patient. But if the patient says, I don't consent, but then you still see these risk factors, and then the patient does not have capacity, then you have no choice but to call in a crisis team who will come and assess the patient. You are going to be with the patient, call in a crisis team for the crisis team to come and assess. And if they need be, they are going to admit the patient under, a mental health act. So basically, I hope you are getting the scenario. Patient has capacity to keep himself safe in the community, so you are still going to nurse the patient in the community. Patient does not have capacity and is willing to be admitted. Patient is being admitted as an informal patient. The patient does not have capacity but is unwilling to be admitted. Here you have to call in a crisis team. They come and do the assessment, and if they need be, they are going to admit the patient. And in this case, the patient is going to be a former patient. These things I mentioned is very, very important, because when you get to your planning, your very first statement or your very first intervention there, you are going to mention these things. Whether the patient has capacity and has consented as an informal patient, or the patient does not have capacity but the patient is not consenting, and therefore the patient is admitted as a former patient under a mental health act. These are very, very important. And then aside that, the next thing is the risk factors. The PHQ-9 here will help you a lot, especially if patient is at risk of malnutrition. What it means is that on your PHQ-9, the patient is likely to have scored 3 for nutrition, which means that the patient has not eaten for the past, let's say, 4 or 5 days. And therefore, the patient is at risk of what? Malnutrition. If the patient has not slept for the past 4 days, then you should know that that one too is also another risk factor. And then the patient has suicidal thoughts. The patient is thinking of hurting or killing himself. Basically here, then you should know that that one too is also another risk factors. And then when it comes to mania, the patient can be so hyperactive that the patient is not eating. The patient even forgets to eat. The patient forgets to sleep. The patient forgets to take care of himself. So self-care deficit, sleep, that is difficulty in sleeping or sleeping too much, depends. And then risk for malnutrition, because the patient is so hyperactive that the patient is not also eating. And then the patient is also at high risk of injury, because the patient is not also doing what? The patient is moving about and stepping on things. The patient can hurt himself, but they don't really care. So in the exam situation, you can even meet a patient there, they have plasters on their hand with red thing on it to suggest that the patient have been hurting themselves, but they don't really care about that. So in mania like that, when you see something like that, so many cuts on the patient, you should know that this patient is at high risk of what, causing more hurt or causing more harm. Here, causing more injury. Please, here it is risk for injury, not harm. A manic patient will never kill himself because they are so busy doing so many things that they don't even have time to think about suicidal thought. DS is a risk for injury. They end up cutting themselves, but they don't really care about the cut and all of that. In such a situation, you need to keep the patient safe. So in such a dicey situation, that is where you also suggest admission for the patient into the ward. And then the patient can also come in as an informal patient. That is if the patient consents, or the patient can come in as a formal patient if the patient is not consenting, but you still feel that there is a need for the patient to be admitted. So that is for the mania, and then that is also for depression. So you can see it's very, very interesting. Very, very interesting, but it might look so cumbersome because I've spoken a lot. So what I'm going to do, as I said, is that I'm going to get one of my friends here, and then we are going to practice. If we are going to practically show you if it is depression, how the questions are going to be like, and we'll practice for if the patient has capacity and is consenting, or the patient has capacity and can be taken care of in the community. And then if the patient does not have capacity and is coming in as either a formal or an informal patient in the hospital. Basically, we'll practice that. And then when it also comes to mania, if the patient has the capacity to keep himself safe in the community, we'll talk about that. And if the patient doesn't have capacity and then we are recommending admission, we'll also talk about that in mania. So basically, we'll talk about the two phases. We'll do practical for it for you to see, and then at the end of it, you see how each of these is done. And the last thing is that one good thing about this assessment is that once you get to the point where you tell the patient whether the patient has capacity or not, and then you make mention of the risk factors, you follow it up with your planning, all right? Or you follow it up with your care plan. And basically what you say is exactly what you are going to write in your planning phase. So basically, for example, I've been able to identify that the patient is at high risk. The patient has told me that, yes, life is worthless and he thinks he's going to kill himself. He even has a plan. And I'm going to admit this patient. I'm going to tell the patient what I'm going to do for him or her in the ward. And I'm just going to start by saying that, all aspects of your care will be explained to you when you are admitted. We'll be checking your vital signs, and then we'll escalate as per the new score. We are going to have one-on-one with you at the ward. So you are telling the patient what you are going to do on the ward. And that is exactly what you are going to write in your care plan, which is the planning. So if you are able to do your assessment very well and you get to the planning phase, it becomes very easy because in the assessment, you've already identified your two problems. And then you are now going to give care plan. You are just going to speak your care plan in the assessment phase, and it's going to be very, very simple for you when you get into the planning phase. So basically, as simple as that, that is the assessment stage. All right, that is assessment stage. You are giving a patient, talk to the patient, know whether it is mania phase, know whether it is depression phase. Know that in depression you use the PHQ-9. In mania, you are likely not to use the PHQ-9. Determine whether the patient has capacity to keep himself safe in the community to continue treatment, or the patient is not having capacity to keep himself safe in the community. Therefore, the patient will be admitted. And in admission, it's either the patient is coming as a formal patient or as an informal patient. Tell the patient what you are going to do for the patient in the ward if the patient is admitted, and that is exactly your care plan. And if it's in the community where you are not also going to admit the patient, tell the patient what you are going to be doing for the patient in the community. And that is also your care plan if the patient is still to be nursed, or if the patient is maintaining the community to be nursed there because he or she has the capacity. So as simple as that. Basically, that is the overview of the assessment stage. And it's as simple as that. So as I've said, I would do a practical on the assessment stage, and then it will be posted probably in the next 1 week. I'll post that video. First we'll do on depression, and then the second one will be on mania. So basically that is it. Please, if you have any questions, make sure you put it in the comment section and I'll be more than willing to answer you. I also put my email there so that you can message me, and then We can get interactive on email. I can even give you my WhatsApp number there, and then we can also chat. Basically, that has been the assessment stage for the mental overview of the assessment stage of the mental health Osce. Very interesting, right? Please, if you have not subscribed to my channel, make sure you subscribe to my channel and then turn on the notification bell. Anytime I post a video, you'll be notified, and then you'll come straight here and then take a look at it. My name is Enos, and this is Work and Wonder. See you in my next video.